Good evening, everyone, and thank you for joining our webinar today. The topic of our webinar today is Understanding Genetics, Carrier Screening, and Targeted Support. We're excited to bring you a panel today who are going to be talking to us. We've got the webinar being hosted by IDFA. Many of you are members of ours. We've got speakers from the Genetic Alliance Australia, the Centre for Clinical Genetics and Genomics Australia, and together we'll explore what carrier screening is and how we can understand this to assist us in our journey. Before we begin today, I would like to acknowledge the traditional custodians of the land on which we meet and pay my respects to their elders, past and present. I extend that respect to any Aboriginal or Torres Strait Islander people who are here with us today. First of all, I'll start off by talking about IDFA. We are a national peak body for people with primary and secondary immune deficiency, and our key priorities are providing education and awareness, care and support by building community, and conducting advocacy campaigns to drive change. The outline of our webinar is on screen. We have a number of different speakers tonight. We have Kathleen McLaughlin from the Genetic Alliance Australia, Rebecca McIntosh, who many of you have come across before. Rebecca's talking about reproductive genetic carrier screening. Dr. Matilda Haas from the Newly Formed Genomics Australia, and one of our own members, Archie, who is going to talk about his experience with immune deficiency. Just a couple of housekeeping items before we get on to the speakers. We're in the process at the moment of organising our 20-year event. So IDFA has been offering support to members for 20 years. And to celebrate that, we have an event on Rare Disease Day, which is the 28th of February 2026. If you are a member, you will have received information about that. So I'd encourage you to register and join us for that event. We have a couple of member engagement opportunities. We've got a new initiative called IDFA Coffee Clubs, where you can organise a get-together in your own local community, and we will support you by providing coffee and encouraging people to get together and talk about their journey with immune deficiency. We're preparing for Rare Disease Day 2026, which is an event that's worldwide and is celebrated by many organisations who represent people with Rare Disease Day. So contact us for information about how you can get involved. We're continuing to roll out our Circle of Support, which is a peer mentoring program, one-on-one support, where we match people who may need support in navigating the health system and navigating their immune deficiency. So we're taking applications for 2026. And now let's move on to our presentations. So our first presenter for tonight is Kathleen McLaughlin. Kathleen is from Genetic Alliance Australia. Kathleen is passionate about providing an equitable and supportive genetic service to families affected by genetic disease. She's a certified genetic counsellor with many years of experience in both general and prenatal genetics in public and private industries. So I would like to hand over for our first presentation to Kathleen.
Thank you. Thank you for the introduction. Let's see if we can get this. Okay, hopefully everybody can see that presentation. Okay, so I'm going to talk to you just briefly about what Genetics Alliance Australia is and what their vision and mission is and how you may wish to use them and advocate for people with genetic conditions. But I'm going to speak from with two hats on. So first as a board director for Genetics Alliance Australia, and I'm speaking on behalf of the company and CEO Emma Bonza. I'm also a genetic counsellor at RPA Hospital, so I will have a brief introduction into the carrier screening for you as well, but my colleague Beck's going to tell you in much more detail all about that. So, what are the vision and mission for Genetics Alliance? So, we hope to see at some point a future where genetic advances bring answers, treatments, connection, and care, no matter how rare. So that's a bit of a wish, and hopefully we can do that over the years of all the work that we do advocating for people. And our mission is that we champion the rights and priorities of people living with rare, genetic, and undiagnosed conditions. We link families, communities, and systems to improve access to diagnosis and care, build knowledge, peer connection, and self advocacy. So they're our overarching goals. So we have a lot of pillars that we work by, and where we are really strengthening and working on each of these pillars. But one of the ones that I think is most important is about the connection and the advocacy of people with rare disease. So we really try to aim to connect people that have got a genetic diagnosis with others with similar conditions, and trying to help them set up networks and community support, and getting the support that they need to navigate the health network, which is pretty awful and difficult when you get a new diagnosis. And we do that by our genetic health navigator, which I'll explain a little bit further later. So our website has been newly updated, hasn't been completed just quite yet, but hopefully January and February, Emma will launch that, and it'll be a very usable and easy website for people to navigate and to obtain a lot of information. So, what is reproductive carrier screening? What are we talking about when we say reproductive carrier screening? So it's a way of identifying individuals and couples who are at risk of conceiving children affected by either autosomal recessive and X-linked conditions. So I'll explain what those two things mean in a minute. But there are a lot of ways of inheriting different genetic conditions. But for reproductive carrier screening, we are really focusing only on those two types of inheritance. And we are also screening individuals without a family or personal history of a disorder. So people don't have to have a genetic condition before they do carrier screening, which was the way many years ago. But now we can actually do this carrier screening for couples without any history, without any known genetic condition, and see whether they're at risk or not. So let's get back to the X-linked and recessive genetic conditions. So you may all remember that we all have 46 chromosomes in a cell, and the first 22 pairs are the same for males and females, and the last pair are the sex chromosomes. So here on this X-linked diagram, you can see that a female has two X chromosomes and a male has an X and a Y. If a female has a genetic change on one of her X chromosomes, she's said to be a carrier of an X-linked condition because it's on the X chromosome. Females are lucky to have two X chromosomes. So if we have a genetic change on one of them, we have a backup copy. So we've got a copy of that gene on the other X chromosome that's working perfectly well. Boys, however, only have one X chromosome. So if they have a genetic change on that X chromosome, they don't have a backup copy because they've only got the Y, so they are more severely affected by any genetic change that's on an X. So when a female is a carrier, sometimes they have mild features of that genetic condition, but often none. And then when they have a child, for their boys or their sons, it's 50% chance whether they pass that condition on, and the boy will be more severely affected. And for females, it's 50% chance whether they're a carrier. Recessive genetic conditions, however, are on those other chromosomes that have got nothing to do with boys or girls. So it's the same for males and females when we have carriers of these types of conditions. Again, we have two copies of every gene. And so if we have a genetic change on one of them, on one of those chromosomes, then we're said to be a carrier and we're unaffected. Carriers generally don't manifest any symptoms, but that's not, we never say never in genetics. There's always, exclusions to the rules, and sometimes that's the case. So if both mum and dad are carriers of a genetic change on the same gene, then they are at 1 in 4 chance of having a child affected with that condition. They're also at 1 in 4 chance of having an unaffected child, or a 50% chance of having a child that's a carrier like themselves. So that's just the basics of X-linked and recessive inheritance, and I'm sure Beck will cover it again to just reiterate some of those points. But what we're really trying to say is that each individual genetic condition, while quite rare, if we put them all together, that comes up with between autosomal recessive and X-linked around 2,500 genetic conditions. So it's really worth considering genetic carrier screening in some instances. And these types of genetic conditions, they affect all age groups, all body systems, and many of them have a childhood onset. And here, because we're talking about immunodeficiencies, the most common way of inheriting immunodeficiency conditions are either X-linked or recessive. Now, you may recognize some of the conditions that I've listed here that are either X-linked or recessive. Many of these conditions are on those broad carrier screening tests because they are inherited in that way. There'll be some that are very rare or very difficult to test for, and therefore they're not on those tests, but many of them are. And if you're unsure, there's always a genetic counsellor somewhere that will be able to help you, or Genetics Alliance Health Navigator, to find out whether the particular condition that you're worried about is on one of the carrier screening tests. So why do we offer carrier screening? Because most of these conditions that we're talking about are very serious. They have serious health implications. A lot of them, and 20% of them can cause infant mortality, and 10% of them cause pediatric hospitalizations. And we found by doing some research in Mackenzie's mission that 80% of couples who have an affected baby have no family history. And we also know that most couples who learn about their carrier status following a diagnosis in affected child actually wanted to do something about it. So that's a good thing to think about. So what are the different types of carrier screening at the moment? So we can either do a single gene carrier screening test for a person that has a genetic condition and they want to test their partner to know the risk of having a child with that particular condition. We would just offer carrier screening for that single condition. That's possible for most conditions. Some people choose just to do the 3 condition screening, which is currently covered by Medicare, so there is no cost. And that includes the 3 most common genetic conditions: cystic fibrosis, spinal muscular atrophy, and Fragile X syndrome. Or many couples are choosing to do expanded carrier screening, which can include anywhere from 50 to 700 different genetic conditions, and many of those are the genes associated with the immunodeficiency conditions that I listed before. So what are the issues? Well, there are many. There are many issues with doing genetic testing full stop. And a lot of these questions, I think, are pretty common, and what we hear when we're doing a genetic counselling session, or for those people that are ringing our genetic health navigator at GAA. And I won't answer all these, and maybe Beck's going to cover some of those questions. But the best way to find out is to usually ask for a genetic counselling session or to speak to a genetic counsellor, or you could go through the Genetic Health Navigator at Genetics Alliance. So what is our Genetic Health Navigator? Well, at GAA, we have seen the need to bridge the gap for individuals and families that have a genetic diagnosis or are in the middle of the pathway of getting a genetic diagnosis who are very lost. So they often don't understand the health system, and it's quite complicated, as we all know, and they are looking for evidence-based information and assistance in trying to work out where to get support, where to get emotional support, where to get information on NDIS or different services. So we've done a pilot project about how accessible and what the need is for this genetic health navigator. And we realize that it would be very popular and definitely there's a need. We just need some funding, and we're lobbying the New South Wales government and federal government at present for that. So these are the contact details for Genetics Alliance to reach out, and if you need some support or just to help link your services and get that known within the GAA group, because we're a bit of an umbrella group and try and link lots of different support groups together. So hopefully I've provided a little bit of information for you to where to find some help. Thank you very much.
Thank you, Kathleen. That was a fantastic presentation. And I think that Genetic Health Navigator is something that can be really relevant to a range of people with different rare disease and other disease. So we'd be more than happy to help you advocate for funding for that, because I think that's a really, really worthwhile service to be able to provide people. So thank you so much for that. It's a really interesting presentation.
Thank you.
Our next presenter is Rebecca McIntosh, who is a certified genetic counsellor with over 15 years of clinical experience, practicing mainly in general genetics. She managed to luck out early with her dream job at Sydney Children's Hospital, and Beck's worked here for the majority of her career. Beck's also been part of IDFA in many ways. She's part of our healthcare professional panel, and she's done a number of webinars with us previously. So I will hand over to you, Beck, for your presentation. Thank you.
Thank you so much. And Kathleen's beautifully teed me up. So many of my slides I'm going to skip through very quickly. Hopefully you can all see that. So I am just very quickly going to also say very grateful thanks to one of my colleagues, Ron Fleischer, who's given me the idea for some of these slides and sent them to me as well. So Kathleen's already very kindly set up beautifully what, who, why, how, and when carrier screening, but I'm just going to tease out a few things, I think, in more detail, and hopefully we can kind of flesh out exactly what carrier screening is and who would want it and why you would want it and how you access it and when you might consider it. So I think we probably now all have a good handle on what is carrier screening. So it is a screening test to identify individuals and or couples who are at risk of having a child with a serious genetic condition. You don't have to have a family history. You can have a family history, but you don't have to have one. But importantly, it's not intended as a diagnostic test. So if you already have a genetic condition, or if you're being investigated to see if you yourself have a genetic condition, this is not the test for you. This is really about your own family planning. So you don't have to have a genetic problem. The whole goal is about your family planning. So the answer to the carrier testing is really to allow for preventative measures, including planning for IVF, or to use a donor egg or donor sperm, or consider adoption, or to test an active pregnancy. And as Kathleen said, we're really testing for autosomal recessive and X-linked recessive diseases. And Kathleen's beautifully gone through all of these things and highlighted a couple of these patterns of inheritance already. So but really we're saying that X-linked autosomal recessive inheritance is a pattern of inheritance which requires both parents to be carriers, and it affects both boys and girls. And some examples in the immunodeficiency world is ADA deficiency, or the one that all the medical students always get taught, but is actually very rare, which is leukocyte adhesion deficiency, and some forms of hemophagocytic lymphohistiocytosis. And yes, I did practice that, HLH, but not all forms of HLH are recessive. And then X-linked recessive inheritance is the condition that predominantly affects boys, and females are carriers. And some examples include X-linked agammaglobulinemia, X-linked chronic granulomatous disease, X-linked SCID, and Wiskott-Aldrich syndrome. So why would you do it? Well, serious genetic conditions account for a 20% infant mortality rate. And at the moment, the suggestion is about 10% of pediatric hospitalizations. I would suggest that that number is probably a little low. They're the ones that we can directly associate back to a genetic condition, but they're the genetic conditions we can diagnose, and we probably can't diagnose them all. So it's probably actually those hospitalization numbers are probably a bit higher. And we know that genetic conditions are individually rare, but collectively, if we put all the genetic conditions together, they're quite common. And as Kathleen has very beautifully pointed out, 80% of couples will have an affected baby, but there's no family history. And now we're in an era where we're technologically advanced enough to make this kind of screening test possible. And we've done a lot of research. We've asked a lot of people. We've done a kind of broadly asked generally clinicians, professional bodies, patients, the general public, is this something that you want? And the resounding answer is yes. We also know that though these things are often rare individually, we are all a carrier for probably at least 1 to 2, maybe 5 to 10 recessive or X-linked conditions. And so every single person on the line in the world is potentially at risk of having a child with one of these genetic conditions. And so that's why we want to be able to offer screening to people, because everyone's at risk. No one's off the hook. And here's some examples about the carrier frequency. Cystic fibrosis is the one that is lauded in the general population as having a high carrier frequency. Tay-Sachs disease is relatively high in terms of their carrier frequency in the Ashkenazi Jewish population. Ataxia telangiectasia, again, a tongue twister. The carrier frequency is said to be 1 in 100 in the European population. That's probably an overestimate, but let's go with that number for the moment. So what we used to do back in the day when I first started in genetics was that we would screen high-risk populations for things that we knew were common in that population. So thalassemia is a good example, Tay-Sachs disease in the Ashkenazi Jewish population. Or if you had a baby with that genetic condition before, we would screen you and your family for that one genetic condition that was in your family. But that, as a one gene at a time, was a relatively inefficient way to do testing, and it was pretty costly. And so now we're in a new era. And now, because of the thing called next generation sequencing, it's actually much more cost effective and time effective to analyze lots of genes in parallel, all in one go. And so lucky for us, it's a similar cost and turnaround time than it used to be 15 years ago to do one gene at a time. We can do lots of genes all in one time, which is great for things that are individually rare, but collectively common, which is the situation we're in with those X-linked and autosomal recessive conditions. And so that's fabulous. And when it comes to money, which is really what the health dollar is all about, Medicare has sort of come to the rescue, but only sort of. And so back in 2019, the Royal Australian and New Zealand College of Obstetricians and Gynecologists, who see a lot of pregnant people, they came out with a statement saying, well, now we're in this era, we should be offering this kind of testing to couples. And that we should be offering at least the test for the things that are common, which is cystic fibrosis, CF, spinal muscular atrophy, SMA, and Fragile X syndrome. So we should be offering those 3 things as a baseline. And screening with expanded panel testing should be available to many other disorders up to hundreds. And so Medicare came to the party and said, we will do the things that are common, because that's what Ranscock said. And my colleague Ron has put this slide together beautifully and said, well, Medicare will pay for the baseline, but if you want any extras, it's kind of like getting upsold at McDonald's, you have to pay for it. So that's expanded carrier testing. So what does Medicare pay for, and what does that mean if you just want to do the Medicare covered things? So if you want CF, SMA, and just Fragile X, how does it work? Well, that's covered by a Medicare item. And if you're a GP or a doctor out there, that's the number that you're looking for. And that's for women who are pregnancy planning or who are already pregnant. And it's done in a sequential manner. So the women are tested first, the woman who's planning pregnancy or pregnant is tested first, and their partner is only tested if she is found to be a carrier. So it's done woman first and then partner. The turnaround time is about 2 to 3 weeks. It's available in Australia through Australian laboratories, which is great. Previously, when we first started doing genetic testing, we had to send a lot of things overseas. So doing it locally is fabulous. And about 1 in 20 individuals we found to be carriers. And that's individuals. And we're really talking about couples risk, but you have to be aware that we're doing them one at a time. So about 1 in 20 people will be found to be a carrier. What does that mean? Well, but what's the downside about doing just Medicare? It's really limited to things that are common in the Caucasian population. So CF is what we call a pan-ethnic disease. It happens all over the world, but it's mostly really common in the Caucasian population. So it's not, and so this kind of package is only really useful for people who have Caucasian ancestry. And because of the sequential nature, because we test the woman first and then their partner, it takes a little bit longer if she is a carrier. And so there may be a delay in clarifying your reproductive risk by doing it sequentially rather than doing them together. So if you're already pregnant, it might take longer. Sometimes CF variants, because there are a lot of them in the gene, sometimes they predict a milder phenotype, and that can be a bit confusing. And same with Fragile X. Fragile X is a very tricky gene, and sometimes we can get pre-mutations which are very complicated. And for individuals with a family history, as Kathleen said, of an immunodeficiency, if there's a known gene in your family, this test is not going to be useful for you because those three genes are not the genes in your family are not covered on the Medicare test. But just very briefly, what is cystic fibrosis, spinal muscular atrophy, and Fragile X? CF is a health condition that affects your lungs, your digestive system, and your reproductive system. It's caused by a change in the CFTR gene. It's inherited in an autosomal recessive fashion. It's on the newborn screen, and there are active treatments now. People are living really long lives now. It's really great. Spinal muscular atrophy is also an autosomal recessive condition that affects your muscles and causes weakness. There is now treatment. The condition can be quite variable, but certainly for infant onset, it used to be a life-limiting condition, but there is now an active treatment and is on the newborn screen. And Fragile X is one of the most common causes of intellectual disability, learning issues, behavioral and emotional problems, and that is not on the newborn screen. But about 1 in 250 women and 800 men are thought to be carriers of a pre-mutation, which is not associated with the full Fragile X syndrome, but can be a bit complicated. But it is important to remember that these three things are not associated with immunodeficiencies, like an inborn error of immunity. So then we're really talking, if you're thinking about this as making sure that your familial condition or screening for immunodeficiencies more broadly, we're really talking about expanded screening. And so what does that mean from a practical point of view for you? So part of it can be subsidized by Medicare sometimes, if you tack on the kind of 3 gene as part of that, but there's exceptions to that rule. And it takes a little bit longer. And depending on the size of the panel, because there are multiple panels and there are multiple laboratories, about 65% of individuals will be found to be carriers. But again, it's all about your risk as a couple. So 1 out of the couple might be a carrier, but it all matters about your couple's risk. So overall, about 1 to 2% of couples will be at high reproductive risk where both of them are carriers for the same genetic condition. It is especially relevant for consanguineous couples where you have a common ancestor. And so there might be a carrier status tracking through the family. These expanded carrier the expanded carrier screen panels can look for recessive and X-linked conditions that are associated with familial immunodeficiency. And Kathleen's beautifully highlighted some in a previous slide, and I'm going to show you some as well that I've found. I've not found an exhaustive list. There are a few pitfalls to this. It's expensive. So the prices kind of range from $600 per person if you do them one at a time, or $750 to $1,500 if you do them as a couple. And again, this is dependent on the price of the size of the panel, 1,500 being the largest panel. There are hundreds of rare conditions, and some of them have variable expression. So some of them, it depends on the change in the gene as to how significant they might be in terms of how they would present in a child. And that leads to the potential for very complex results and therefore complex genetic counseling. Most of these private companies provide a genetic counselor if you have a result where you're at high risk. But also, as Kathleen said, there are a lot of friendly genetic counselors out there, including myself, who would be very happy to see you if you did end up in that high risk category and were thinking about having a baby. There are very occasional implications for carriers, and I'm going to come to that at the end of my talk. But some examples I've also found and this was not ever meant to be an exhaustive list. I just had a quick look through the 1,000 gene panel on one of our local labs and just pulled out ones that seemed to be relatively familiar, but this was not ever meant to be an exhaustive list. But you can go and mine the list and see if your gene of interest in your family is there. But as Kathleen mentioned, not all the genes will be there because some of them are very rare. They have there are 2,500 genetic conditions that are X-linked and recessive, and these gene lists are about 1,000 large. So there will be some missing. So when would you do it? And what does it cost? Well, different laboratories will cost different things, and often the larger the panel, the more it costs. And if you do it as a couple, the cost is higher. Sometimes there is a benefit in doing it as a couple upfront because if you're doing it sequentially, you're sort of paying twice. The test is really designed to be done prior to conception, so like pre-pregnancy, but it can be done in an active pregnancy. We usually suggest you do it early on. That gives us like the majority of time to make decisions. The test can usually takes about 2 to 6 weeks, depending on which option you take. And if you do the Medicare option only, the testing is staged. So the female first, and then the partner. So some things you might want to think about in terms of what you decision making about whether you want this test. Are you actively pregnant? Is this information you really want to know at the moment or ever? Will it impact on your current pregnancy to have this now? Will it create more or less stress? Would knowing that you're a carrier of a genetic condition create worry or less worry? Would you prefer not to know at all? Would it impact on this current pregnancy? So I've just got three kind of potential outcomes of testing that I will run through, and it's the same like made up scenario every single time, but just three potential different outcomes. And there are many potential outcomes, but I've just made up three just to kind of illustrate what might happen. And I picked ADA deficiency because it was letter A and it was the first one I came across. So this is a completely made up case, not real. So ADA deficiency is inherited in an autosomal recessive fashion. It's caused by changes in the ADA gene. And Jody and John have presented to think about having expanded carrier testing because they have a family. Jody has a family history of ADA deficiency in her nephew, Joseph. And so her sister is a known carrier, and so Jody therefore has a 50% chance of being a carrier. Jody's never had any carrier testing, and so Jody and her husband John decided to have expanded carrier testing to determine if they are carriers of ADA deficiency and any of the other things that are on the expanded panel, and then to determine their risk of having a baby of recessive and X-linked conditions. And they choose the biggest panel they can find, which is 1,000 genes. So option one is that the first result comes back and Jody is a carrier for ADA, but nothing else. And John is not a carrier for ADA and he's not a carrier for anything else. So their chance of having a baby with ADA deficiency and the other things that they were tested for is now significantly less than the general population, but we can never make it zero because there are potential ways that we can look at the genetic material that the test doesn't look at, or that the spelling changes, that there are limitations on the test essentially, that we can never make the risk zero. It's a screening test. But the residual risk of this through this test means that their residual risk of having a baby with ADA or any of those other 1,000 conditions is less than the general population. So same case, Jody and John, they've never had a test, but Jody is at risk of being a carrier. Jody and John are not carriers of ADA, but Jody finds out she's a carrier for cystic fibrosis. It's relatively common in the general population to be a carrier, and John is a carrier for spinal muscular atrophy. I think the carrier frequency is 1 in 40. Neither of those things are a massive surprise, but they're not a carrier for the same thing. So that's useful. And because they're not carriers of the same condition, their chance of having a baby with CF, SMA, or ADA is now very low. But there always remains a residual risk due to the limitations of testing. And so they've reduced their risk of having a baby with those 1,000 conditions to less than the general population. So last outcome, they have the test and they both turn out to be carriers of ADA deficiency. And they did the test because they really wanted to know. And they've now clarified that they have a 25% chance of having a child with ADA deficiency. But importantly, they've also reduced their risk of having a chance with anything else. So that's really useful to them. But now they know they are at risk of having a baby with ADA. So what would they do with that information? Put too many clicks in. There we go. So if you are a carrier, what would you do with that information? And so you've got a couple of options. You could just get pregnant and see how you go. Lots of these conditions, and we're now moving into a realm where genetic conditions are being more readily able to be treated. And so having this information now prepares you for treatment at like straight from birth, at delivery. So some people just want this information to plan for what they would do post-delivery. And so one thing you could do is just naturally conceive a pregnancy, have no testing, test at delivery. I guess you could also do a chorionic villus sample, which is a biopsy of the placenta, because the DNA from the baby is the same as the sample in the placenta, or same as the DNA in the placenta. Or you could do take a sample of the amniotic fluid at 15 weeks, and we could test the baby that way. And if the baby had the same genetic condition, you would have the option of what you would do with that information, either continue or stop a pregnancy. The other option is not a natural conception, but an IVF conception. And once the embryos are conceived in the petri dish, test those embryos and only implant unaffected embryos. And funding is available there's a Medicare rebate for IVF, and there's also a Medicare rebate for what we call pre-implantation genetic testing. So that's the testing of the embryos for conditions for which there is no curative treatment and a severe limitation on quality of life. And I would imagine immunodeficiencies would be covered under that. And your local genetic service or your immunologist would just need to write a supportive letter to your IVF specialist. Even with the Medicare rebate, there's still usually an out-of-pocket cost, and there are very few public IVF PGT companies available, but there is a Medicare rebate for this available now. Kathleen mentioned earlier on that occasionally the old adage used to be that if you were a carrier of a recessive genetic condition, you didn't have any symptoms. That isn't always true. And occasionally we find unexpected results on these expanded carrier tests. And so healthy individuals find out that they actually have health implications for themselves. And so some carrier status do infer health impacts for carriers as well. So this is something you should know. The bigger the tests, the more we find, and that might have health implications for you. So whilst it's not a diagnostic test for your immunodeficiency, we might accidentally find out something that infers a health impact for you. One classic immunodeficiency example is ataxia telangiectasia, which is a childhood onset immunodeficiency with a neurological phenotype. And it's caused by two inherited changes, one from mum and one from dad, in the gene called ATM. But carriers don't have an immunodeficiency or neurological phenotype, but they have a predisposition to cancer. And there is one particular variant that makes women much more susceptible to breast cancer, but generally all people who have changes in ATM, which cause AT, are more at risk of various different types of cancer over the general population. And the carrier frequency of changes in ATM is nominally 1 in 100, so that's actually pretty high. So you could do a test, find out that you're not at risk of having a child with AT, but you do have an increased risk of cancer. So what's my take-home message? This is a screening test for pregnancy planning, and it's for people who are pregnancy planning or pregnant, and to reduce your risk of having a child with a genetic condition. You can get it ordered through your GP or your fertility specialist, and I think some of the ultrasound care centres who look after pregnant people are ordering it as well. And you can order it pre-pregnancy or in the early stages of your pregnancy. And we're looking for autosomal recessive and X-linked recessive serious genetic conditions. That's what we're screening for. And that's me done. Thanks so much.
Thanks, Beck. That was absolutely comprehensive overview for anyone who may be in those stages of family planning. And we will make this webinar available via recording afterwards. So if you wanted to go back and hear any of those previous tips or information, that will absolutely be available to you. So thank you. Our next speaker is Dr. Matilda Haas, who is the Director of Community Impact and Partnerships at Genomics Australia, which is a newly formed organisation. It started in July 2025. Matilda leads work to ensure community voices and values are embedded in the integration of genomics into healthcare. And we've only just met Matilda at IDFA, but it's an organisation that we will continue to engage with. Matilda has a background spanning neuroscience, genetics and health research, and has helped to shape national programs advancing genomic medicine, and is passionate about translating evidence into practice to benefit all Australians. Welcome, Matilda, and I will hand over to you now.
Thanks very much, Carolyn. Okay, hopefully that's sharing well. Just give me a shout if it's not. Okay. Thanks again, Carolyn. I'm delighted to be here this evening to share with you some of the work that Genomics Australia and Australian Government are doing in this space and more broadly. I don't need to introduce myself, I don't think, after that introduction, so I'll just get straight into the presentation. I too would also like to respectfully acknowledge the traditional custodians of the lands across Australia and pay my respect to elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander people today. And I especially want to acknowledge that I'm joining this evening from the lands of the Wurundjeri Woiwurrung people. So this outline slide just provides a bit of a brief roadmap for the presentation, where I'll start by setting the scene as to what genomic testing, including carrier testing, is currently being offered in Australia, particularly through Commonwealth public funding. I'll then be covering the role of Genomics Australia, its governance functions and priorities, and then I'm going to highlight some of our engagement work, which is particularly through the networks that we're developing and also the community impact and partnership section priority projects. Hopefully by structuring the presentation this way, you'll come away with an understanding of Genomics Australia's purpose and our approach to integrating genomics into healthcare, and how we're building in approaches from the beginning to ensure that individuals, families and communities are supported through their genomic healthcare. So the current state of health genomics in Australia, there were more than 600,000 genetic and genomic tests done in the 2024-25 financial year that were funded by Medicare. And there will have been many, many more tests done that were funded by the states and territories through their health systems. To put this into context, NHS England, who are considered a world leader in genomic testing and integration, does around 850,000 genetic and genomic tests per annum. In Australia, $160 million in Medicare benefits was paid in the last year, and there are now 161 tests subsidised under Medicare. We've also seen $651 million invested in genomic research funding to 220 separate grants, and there's also been additional funding towards precision oncology programs. Specifically relating to carrier testing or screening in Australia, carrier testing is funded for several conditions, and I've listed them on the screen there, but noting none of them relate to immunodeficiency syndromes. So carrier testing is funded for these conditions, particularly where there is a family member who has received a genetic diagnosis for a condition using a companion or complementary Medicare funded test. So if a relative receives a diagnosis from a Medicare funded test, there's usually a carrier screening test item available that could support family members to also have testing done. There's also reproductive carrier screening available through Medicare for testing for people of Ashkenazi Jewish descent for 12 genetic conditions for which they have a greater chance of developing. And aside from that, carrier testing may be funded by the states and territories through their genetic services, or can be self-funded through genetic services or direct-to-consumer tests. Expanded carrier screening, which we've heard about already previously tonight. So this is where hundreds or even thousands of genes are tested, is available in Australia, but would usually be self-funded. Also, I just wanted to quickly mention here that for all of these Medicare tests, there would usually be genetic counselling recommended as a part of the delivery of these Medicare services. So while I mentioned that expanded reproductive carrier screening is currently not publicly funded, the Australian government supported research into expanded reproductive carrier screening via the Mackenzie's Mission study, where more than 9,000 couples had testing to look at over 1,300 genes responsible for 750 severe conditions. The study demonstrated that carrier screening can be delivered nationally across different ethnicities, and that the screening is cost-effective and acceptable to the community. While the study modelled the support and follow-on services that are needed to be delivered in conjunction with reproductive carrier screening at a population scale, implementation considerations are still being worked through by government, and Genomics Australia will have a role in these genomics-informed population screening programs. So I just want to spend now a few minutes talking about Genomics Australia, because, you know, while I've outlined that there's been great progress in the availability of genomic testing through my last few slides, there's also still work to be done. So because of that, Genomics Australia was established in the Department of Health, Disability and Ageing on the 1st of July this year. Our vision focuses on routinely incorporating health genomics into clinical practice to prevent disease and personalised treatment. Our mission emphasises our role in providing national leadership, coordination and expertise to integrate genomics in a culturally safe, ethical, equitable manner, ensuring benefits reach all Australians effectively. We've identified 5 key activities that will help us to achieve our mission. And these include leading on addressing complex health genomics issues, providing expert health genomics advice on issues that have national significance, conducting projects to give effect to the National Health Genomics Policy Framework, providing a national and international presence in health genomics. And importantly, number 5 is about informing the Australian public about health genomics and giving stakeholders a focal point for engagement and communications. The governance structure of Genomics Australia is outlined here, showing our reporting line to the Minister, Mark Butler, through the Department of Health, Disability and Ageing. It highlights the key role of the Australian Health Genomics Commissioner, Tiff Bortwood, who will be supported by the recently announced Genomics Australia Advisory Council. This advisory council importantly includes 2 consumer representatives. Other key groups include the Health Technology and Genomics Collaboration, which has representatives from each state and territory, and also the Aboriginal and Torres Strait Islander engagement mechanism. Another really important feature for us is the networks, which are being established for our engagement and information exchange, and I'll come back to those a bit later. So as mentioned, Tiffany Bortwood is Australia's first Health Genomics Commissioner, and Tiff has about 30 years of experience in genomics, both in diagnostics and in research. Her role specifically will be to provide expert advice on genomics and integrating into health technologies into the health system, providing a national and international presence in health genomics, and ensuring that the sector is involved in the formation of government policy. Genomics Australia is also working towards establishing its First Nations engagement mechanism that I mentioned on the governance slide. And our intent with this is to establish an engagement mechanism that's culturally appropriate and can inform implementation of culturally safe and responsive approaches to health genomics. This slide presents the organisational structure and expertise within Genomics Australia. So Genomics Australia is led by a General Manager, Renee Lucchese, who's very experienced in Australian government. And the team is divided into 3 sections. There's the Innovation and Integration section, which is led by Mathilde Dessel, the Community Impact and Partnership section, which is my team, and the Governance and Engagement section, which is led by Claire Donovan. We've got quite a lot on our agenda in the first 12 months, and these are our first 12-month priorities listed on this slide. It's a bit wordy, but I'll whiz through it. So essentially, we're looking to be building networks across the health genomics sector between Australian government and the states and territories. We also are launching the new National Health Genomics Policy Framework early next year. We're looking to improve access to personalised cancer care, exploring and addressing barriers to research translation, and also beginning horizon scanning, as well as engaging in industry partnerships. The work of my team specifically is shown in the bottom box, where we'll be leading on building those partnerships with Aboriginal and Torres Strait Islander people. We'll be fostering formal relationships with international leaders in health genomics, supporting national approaches to genomic information management, and also working on understanding community priorities, values, and expectations in health genomics. And that last point is something that I'll come back to in my last couple of slides. I specifically wanted to mention the National Health Genomics Policy Framework, as it will set the direction for governments for the next 5 years. Genomics Australia has been engaging with the jurisdictions on establishing this new framework, which is expected to be finalised and published early in 2026. There's 4 strategic priorities that focus on person and community-centred genomics, the genomics ecosystem, data management, and Aboriginal and Torres Strait Islander-led genomics. The strategic priorities are supported by guiding principles on equity and patient empowerment, and the enablers outline the key role for collaboration and strong governance in the framework's activities. The framework's activities are a combination of really foundational activities that bring together a lot of the threads of the excellent progress that's already been done around the country, and also some more new and innovative aims that will help put us in a better position in the framework's 5-year term. I think something that's really important to point out is that in this framework, we've really strengthened building partnerships with non-government stakeholders, including those who represent priority populations such as our rare disease community. My team is also leading on ethical, legal and social implications of genomics in healthcare. And we're already, in our first few months, been actively providing advice on public education and awareness, the workforce, equity of access, clinical safety, and genetic discrimination. In relation to genetic discrimination, one thing that's really important in consideration for those undergoing genetic testing to find out if they're at risk of developing or passing on a condition is that they are not discriminated against when seeking a new life insurance policy, when they've not yet developed any condition themselves. So to achieve this, there have been some proposed amendments to the Insurance Contracts and Disability Acts. And the objective of those amendments is to provide certainty to individuals undertaking genetic testing, whether that be through clinical genetics or through health and medical research, and so that they're assured that this will not impact their ability to obtain life insurance cover or change the terms and conditions of that cover. And so it's intended that this legislation will lead to the increased uptake of genetic testing and therefore provide extensive individual public health and scientific benefits. The bill for these legislation changes was actually introduced to Parliament just last week, and Genomics Australia worked closely with Treasury in drafting the legislation. The legislation will prohibit insurers from using genetic test results, and a clinical diagnosis must be established for inclusion in the underwriting process for insurance. There will also be really large penalties associated with contravention of the ban. And so what we have introduced to Parliament last week is arguably amongst the strongest, most thorough legislation that exists globally. And finally, I just wanted to come back in the last 2 slides to our community engagement work, which will support the integration of genomics and inform our views and responsiveness to the ethical, legal and social implications of genomics. We'll do this initially by developing a suite of mechanisms to understand community priorities, values and expectations. And we'll specifically apply those mechanisms to different questions about genomics in different populations in relation to different types of genomic interventions. So it won't be a one-size-fits-all approach in terms of our community engagement. We'll focus on developing community-facing resources about genomics. For example, we'll be providing some resources explaining the changes to the insurance legislation when it's passed. And we'll also be incorporating public perspectives into our projects. So our key mechanism for these engagements will be our community network. So this is how we will identify and engage with our stakeholders. So how do you get involved? Well, our Genomics Australia website went live just on Monday this week, and I would really encourage you to visit it and sign up to the community network. This will give you the opportunity to participate in webinars and events such as roundtables, as well as contribute to our projects from time to time. And so that's all I have for you today in my summary. But thank you for having me here, and really pleased to speak with you. And please reach out if you have any questions or want to chat. Thank you.
Thanks very much, Matilda, and we will certainly be engaging with you and passing on information to our membership. It's a really important area for people with immune deficiency, and we're absolutely thrilled that this department has been formed, and we're really great to have had that presentation from you. Our final speaker for tonight is an IDFA member, so I'd like to warmly welcome Archie McDowell. Archie lives in Sydney with his partner Kaya and their 2 young children. Throughout his life, Archie has navigated several primary immunodeficiency and autoimmune diagnosis, as well as cancer at a very young age. That eventually led to a confirmed diagnosis of the genetic disorder Wiskott-Aldrich syndrome in 2019. Following this, Archie underwent successful stem cell transplant in 2021. Remarkably, Archie and his partner welcomed a child both before and after his transplant, all while managing the complexities of treatment and the COVID-19 pandemic. So I'll hand over to you, Archie, to share your story. Thanks for being with us tonight.
Thank you, Carolyn. Yeah, thank you for that. I'll just give a bit of a short overview of my health journey and how I ended up getting a genetics test. So yeah, I'm 38 years old, but born in 1987. So at 3, I was first hospitalized with low platelets and diagnosed with ITP, which is idiopathic thrombocytopenic purpura. I'm trying to remember that. 2 hospitalizations, recovered, and my platelets were about 70 to 100. So still low, but not too dangerous. And had a relatively stable childhood health-wise. It wasn't until about my early 20s when I sort of started going a bit awry. I was living in London, and I'd seen a hematologist amongst other doctors, and he had done some testing, and he said, "Oh, your immunoglobulins are low, and you may have this thing called CVID, common variable immunodeficiency." And I didn't get it followed up, had it on a piece of paper and came back to Australia. But a year later, I was back in hospital, this time diagnosed with cancer, non-Hodgkin's lymphoma. So it was through the treatment doing chemo that they, diagnosed me with then common variable immunodeficiency as well as the ITP. My immunoglobulins weren't low enough or borderline to do immunoglobulin replacement treatment. So yeah, we didn't start that. I was 25 years old when the cancer had happened. 8 years had passed. A few more hospitalizations for serious case of pneumonia, viruses. My health wasn't doing too good. My platelets by this point was sort of 55 on a good day. But I was now living in Vancouver. And this time I was then hospitalized with a severe ulcerative colitis flare. And it was this hospital admission. I was in hospital for 27 days, lost 17 kilos. They were wanting to take my colon out almost every day. And I was being really stubborn and said I didn't want to do that. And fortunately, they gave me the option of taking a biologic, which fortunately worked in the time frame to get me out of hospital with a colon. But it was throughout this hospital admission that seeing all the different doctors, one of the immunologists came around and she actually said, "You seem to be collecting autoimmune diseases. Have you ever had a genetics test?" Which I had to check I actually checked my dad. I was like, "Have we ever done that?" And he's like, "No, we haven't done that." So yeah, it stayed with me. Obviously the colitis was the primary focus, but then after leaving hospital, re-seeing an immunologist in Vancouver, as I said, your other colleague said, it might be worth doing a genetics test. And he was supportive. He said, yeah, I think there's, yeah, sure, I think there's a good reason to. But he was also tempered my expectations. He said there's a lot of things it can exclude, and sometimes it leaves still things unanswered. But we organized it in the month waiting for that test, back in hospital, low platelets were 6, hospital for 10 days. Got out of hospital then again, and then we saw the immunologist, and it was the night before I saw him that I got the email from the genetics testing for my genetics testing results, and it came back with a genetic disorder called Wiskott-Aldrich syndrome. And if you looked at the list of the things that Wiskott-Aldrich syndrome can be: low platelets, immunoglobulins, cancer, autoimmune disease, I ticked every box. So it was really, it was the puzzle that fit. And so I saw him the next day, and I actually thought he was going to tell me there's the other part of Wiskott-Aldrich is generally a younger boys present with it. I was 32. He told me that he was retiring next year, and he hadn't ever diagnosed someone my age with it, so he was going to refer me to one of his other colleagues. But at that point, then we sort of had that diagnosis and clarity to kind of move ahead. Wiskott-Aldrich, although it's an incredibly serious genetic disorder, it does have it's fortunate there's a curative path with a stem cell transplant. So yeah, from that diagnosis, we worked towards that. And then in between that period, we had COVID hit, obviously, and my partner fell pregnant with our first child, and we were in Vancouver. So then we returned home, and we did the stem cell transplant, and I finished my remission for that next year. So everything's everything from the stem cell transplant's been a success. My brother was the donor. Yeah, no, it's been a complete success from my point. Unfortunately, my sister, she's a carrier, has 2 young boys with Wiskott-Aldrich, so our family journey is still not finished. But at least we have the clarity. In another scenario, which I would have continued getting sick, probably would have lost my colon eventually, because I would have been still, my ulcerative colitis would still be active, which the stem cell transplant's actually cured as well. And I probably would have been going towards another cancer relapse. And then, my sister would have then had her boys, and they would have not had they wouldn't known the diagnosis themselves. So from that perspective, it's really it's been a really big fork in the road for certainly our family. But certainly the 10 to 15 years prior, it was a pretty big health period of our lives. And so hopefully hopefully we don't have too much more after just another few stem cell transplants. I guess my insights to pass on to others. I did. I guess I got my test in Vancouver. It's and speaking to my sister as well about her experience getting genetic testing. It's very tricky. GPs, it's not a standard test. Certainly, like having a hematologist or immunologist to advocate is really important. Certainly, I'd have my immunologist down at the collection center doing all the forms, because it's a pretty complicated thing to just ask a GP or a doctor. So that would be one of my main pieces of advice to your immunologist or hematologist, or some of the resources the other speakers have said, because it's even some of those information's been pretty good. Thanks. I think that's all I have, Caroline.
Fantastic. Thank you so much, Archie. That was wonderful. It's great to have a member as part of the webinar to share the experience that you've actually been through. So that brings us almost to the end of our webinar, and I would just like to promote one of the resources that we have available, Genetic Diagnosis of Primary Immunodeficiencies. This is available by scanning the QR code. It's also available in a downloadable format if you go to our website, or if you'd really like a hard copy, you can contact us via email and we will send one out to you. I've just launched the poll, so I'd like to ask you to complete the polling questions so that we can improve our webinars in the future. And while you're doing that, I'd really like to thank all of our speakers tonight. It's been an absolutely fabulous webinar. As mentioned previously, we have recorded the webinar, and this will be made available on our website in coming days. So thank you to Kathleen, Rebecca, Matilda and Archie for joining us. And I also would like to acknowledge the sponsors of our webinar, so CSL Behring and Grifols, who allow us to bring these webinars to you on a regular basis. This is our final webinar for 2025. We've got an exciting series for 2026. For anyone on the webinar today, including our speakers, I'd really like to invite you to our 20-year event being held on the afternoon and evening of Saturday, the 28th of February at the Sydney Ridges Airport Hotel. And we have a fantastic lineup of speakers. We also have 150 members attending that event, and we will be looking back at IDFA over the past 20 years and also looking forward as to what we can offer our members in coming years. So again, thank you to everyone who attended. Thank you to our speakers, and wishing you all the best for the holiday season. Good evening, everyone.
Thank you.